Can start,
You
sir.
can go ahead. You can start.
Oh, all right, fine. Well, thank you very much. And nice to talk to you again. This time I'm going to be focusing specifically on the evolution of where we've come in diabetic kidney disease and slowing the trajectory. And hopefully, I will have a very hopeful note for you. As you know, diabetic kidney disease is the number one problem in the world. And you can see from this data that over the next 20 years, the rates of people going on to dialysis will have doubled, and Asia is leading the way, specifically Taiwan, for reasons that are unclear. The last real breakthrough that we've had in terms of interventions to slow diabetic kidney disease were the RENAL and IDEC trials back in 2001, and you can see in both those trials there was a tremendous amount of residual risk that needed to be dealt with. Since then, there have been multiple studies that have been done with a variety of different compounds and different mechanisms, all of which have failed to actually change the natural history of diabetic kidney disease. Now, we've had a number of studies done, especially since the rosiglitazone debacle, looking at non-inferiority trials for cardiovascular safety, but really nothing on kidney disease per se, until the latest agents, the GLP-1s and the SGLT2 agents came in, and kidney data started to be looked at. And the SGLT2 agents to date are the ones that give us the best data uniformly across all spectrums of diabetic kidney disease for having a benefit. I want to go through this and I want to show you how this fits into the armamentarium irrespective of your glycemic control. So we know in this well-done meta-analysis, and by the way, I'll give you a tip, there is an upcoming meta-analysis that should be available to you probably within the next couple of months in JAMA Cardiology that has added yet the ertigliflozin trial and similar kinds of analyses. But I just tell you for right now, you can see that even in people with GFR of less than 60, which you can see at the top, there is uniform benefit in these cardiovascular outcome trials with admittedly very low renal risk. So credence, which I'm going to talk about in a second, needs to be understood is many people are confused because they thought this was a trial that resulted as coming out from these cardiovascular trials. Could not be farther from the truth. We were designing credence starting in 2012, and enrollment, you can see, was way before, almost 2 years before EMPA-REG came out. So this was a true dedicated renal endpoint trial. And just to give you an idea of what we're talking about, these are the stages of kidney disease, and I think most of you saw this if you heard my earlier lecture. And you can see that the cardiovascular outcome trials were in the green, meaning you look over, you can see GFR in these people, 70s, 80s, no albuminuria. I think we'd all agree these are pretty healthy kidneys. On the other hand, when you look at credence, the GFR was much lower, 56. We had significant albuminuria, 927 milligrams per gram was the mean. And looking below at dialysis events, all three cardiovascular trials combined had 29 events, whereas credence had 176. So clearly, this was a renal outcome trial. Just to make a point, 4,401 participants, 99.1% follow-up on everybody. So this was not a trial plagued by dropouts and lost follow-up. Just to make the point, coming into the trial, 15% had heart failure, 5% were already amputees. So this was advanced peripheral vascular disease and cardiovascular disease coming in people in their 60s. The other very important point, and people get confused on this, is in this trial, almost 100%, 99.9%, were already on a RAS inhibitor. They were either on an ACE or an ARB, and at reasonable doses. So I've heard people say SGLT2s are substitutes for RAS blockers. Absolutely not true. This trial, the benefit was seen on top of a RAS blocker. So I need to make that point. The other point is, just to emphasize, this was a true renal population. 31% had a GFR below 45, and 88% had proteinuria greater than 300 milligrams. So this was advanced kidney disease, no questions asked. If we look at the change in hemoglobin A1C, we see that it was not significantly different, 0.25% difference. So the outcome here cannot be attributed to a glucose effect. Blood pressure, on the other hand, was nicely reduced, 3.3 millimeters, not significant, but trending that way, but definitely an effect. And then albuminuria, consistent reduction, 32% through the trial, and you should know that the FDA now acknowledges a greater than 30% reduction that is sustained as a surrogate for a positive renal outcome. So the primary endpoints of this trial are 4, and you can see here ESKD, and the definitions are there so that you can read them. There was a doubling of serum creatinine, as also included, renal death, and cardiovascular death, which was pretty much a MACE type event, but it included heart failure and death due to stroke. So clearly a pretty hefty composite endpoint that's very heavy in terms of renal outcomes. When you look at the primary composite, there was a 30% risk reduction, and clearly the benefit was there, but more importantly, and Ellie Ferranini commented on this as well, a 34% risk reduction in the people that had true renal outcomes. More importantly, there was a 32% risk reduction in people going on to dialysis. So this is important. 32% risk reduction when I already showed you at the beginning the epidemic of people going on to dialysis. So background therapy of ACE and ARB, SGLT2, even at GFRs of 35, definite clear benefit seen here in terms of slowing dialysis progression. Now, did it matter what your GFR was? And the answer was no. Didn't matter if you had a low GFR, high GFR, life was good. Did it matter how much albuminuria you had? No. You had less than a gram, more than a gram, same effect. Did it matter if you had an amputation? No, it did not. Did it matter if you had heart failure? Did not. How about duration of diabetes or history of CV disease? It didn't matter. Everybody, this was an equal opportunity benefactor across the board. So what does that mean, and where does that put us in terms of our trajectory of kidney disease progression? What you have here, and some of you may be familiar with this, is a slide I made many years ago, and it's now been updated, and basically looks at all of the trials that have had at least a 2.5-year follow-up or longer in looking at progression of kidney disease. Some are well-powered randomized trials. Some are 2 or 3 center studies that have had the follow-up. But the point is, if you look at this, in 1980, that's what the X represents, we didn't have ACE inhibitors, didn't have ARBs. We didn't have the quality of glucose control that we had. And the rate of decline in GFR then was roughly between 10 to 12 mLs per minute per year. Enter Renal and IDNT, and we slowed things down to about 4.5 to 5 mLs per minute per year. Still pretty fast, but definitely an improvement. And now, with Credence, we've slowed things down to 1.85 mLs per minute per year. That translates into a 58% per year reduction in GFR decline. And you can do the math real quick, that if you've got a GFR of 35 and people are maximally treated you can buy them a number of years off the dialysis machine. So I think it's important, and what I failed to mention in this slide, is normal is about 0.9 mLs per minute per year. So we're still nowhere near normal. We need a 50% greater reduction from where we are now. And there are trials coming this fall that may actually add yet another level of benefit here with the non-steroidal mineralocorticoid receptor blockers, namely finerenone. So we'll see. But right now, I think people should really be happy because this is really a benefit in terms of where we came from and where we are. Now, everybody says this isn't free. There's side effects. Yes, there are side effects. The big one really that is of concern, especially to non-endocrinologists, because cardiologists are now using this, nephrologists have started to use this, is diabetic ketoacidosis. And I think what's important to understand in this trial is the people that had a problem with diabetic ketoacidosis, first, were either on insulin or sulfonylureas, but all of them had some gastrointestinal problem, volume depletion. They stopped their insulin or their SU, but continued the SGLT2. That's the subgroup that you have to be careful of. So patients, just like if you're on an ACE or an ARB and you develop a GI problem and you get volume depleted, you tell them to stop the ACE or the ARB. Same thing here. They have to stop the SGLT2 if they've stopped insulin or sulfonylurea, and then theoretically you should not have any issues. What was the benefit? Well, those of you that like numbers needed to treat, you can see here for the primary outcome, composite outcome, you only needed to treat 22 people to get a benefit. More importantly, if you look at RRT, renal replacement therapy, you only needed to treat 16 to prevent one dialysis event. And for the cardiovascular minded, you treated 46 to prevent one heart failure hospitalization. So very, very powerful, impactful therapy that clearly we really don't totally understand. And I think for those of you that heard Dr. Farinini's talk, you can see there are multiple mechanisms, some of which he didn't even discuss because there's so many and there's only limited time. So I think it's important to understand that this is a very important class of drugs, so much so that I basically said that SGLT2 inhibitors, and this is in print, are cardiorenal risk-reducing drugs that have glucose lowering as a beneficial side effect. And actually, there is a paper that I can't discuss with you, but there's a paper we've just submitted to Kidney International from the credence in the subgroup of GFRs less than 30, at 174 patients. Those people with a mean GFR of 24 got the same benefit as people with GFRs of 60. No effect on glucose, no effect on renal hemodynamics, still got the benefit. Still got a 3.5 millimeter reduction in blood pressure. So this is not a sodium event. This is not a natriuresis. There's actually good data, and I did not hear all of Ellie's talk, but there's very good data published now in JACC, Basic and Translational Medicine, that this could be sympathetic denervation that SGLT2s are doing. And that would explain why you're getting this effect regardless of glucose change. So very important point for you to know. I want to just preview that at the American Society of Nephrology meetings coming up in October, if they happen, virtually or otherwise, there are going to be two huge trials that are going to add to the armamentarium of this data. One is the Fidelio trial, which you see there in kind of orange. And this is the largest trial to date ever in diabetic nephropathy, 5,700 people plus. And it's powered for renal outcomes. So I'm the principal investigator. I don't know the results yet, but we've stopped the study. I mean, it's done, and we'll know soon. And the second trial is the DAPA CKD trial. And why that's important is that trial has been stopped early. And that trial has at least a third, if not more, people with non-diabetic kidney disease. So we already know it's positive. We need to know the details. These two trials, to my knowledge, are going to be presented at the American Society of Nephrology meetings in Denver in October. And hopefully, if positive, will further solidify and maybe extend our benefit on slowing progression of kidney disease. I want to finish up by showing you that the guidelines have already caught up with a lot of this data. And this is the 2020 ADA guidelines that have been endorsed by the American College of Cardiology and the American Heart Association. And they very clearly state that if you have heart failure or a history of heart failure or kidney disease, this is a predominant finding. Yes, you can use metformin, but SGLT2s really need to be part of that armamentarium to really reduce the risk. So with that, I will finish and answer any questions that you may have. Thank you very much.
Thank you, Dr. George Bakris. It's a wonderful discussion on slowing the progression of the diabetic kidney disease. Can I ask a question to you, Sanjay?
Sure.
You mentioned about the renal death. Renal death in people of a Credence trial. How do you define the renal death?
So renal death was basically, put very simply, people that did not want dialysis. They needed dialysis. They had clear indication for dialysis. They either had potassium issues or they had acidosis or volume issues, and they simply refused dialysis.
Okay. Talking about the diabetic ketoacidosis induced by SGLT2, many of these patients do not have ketone bodies in the urine. Their blood levels are usually normal because they are called euglycemic ketoacidosis. How do you suspect that this patient has the ketoacidosis because of SGLT2?
Yeah, that's a good question. It's unclear. Unless you do a blood test, you really don't know. I will tell you, I've never seen it, but I talked to a friend who did see it, and what he's told me is that the patient called said they didn't feel well, very nonspecific, and there was no reason that they wouldn't feel well, and they checked the blood test, and his bicarbonate was down, and that was that. So I think there's no simple way to do that. In type 1s, it's easier, but in type 2s, it's a little more difficult.
Talking about statins and fibrates in chronic kidney disease, we are confused whether atorvastatin is safe or whether it is rosuvastatin, and fenofibrate has supposed to have action on the mitochondrial endocytosis producing inflammatory response and for protecting kidney tubules. So what is your message for us? Whether it's right atorvastatin or rosuvastatin or fenofibrate? Most of them have high creatinine once we give fenofibrate, but does have a beneficial effect on kidney as well.
Well, here's the thing. I'm going to quote to you the guidelines, the international kidney guidelines on this. If you have somebody with stage 3 CKD, so GFR between 59 and 30, and they need a statin, they should be put on a statin, and there's some evidence that it will protect the kidney. It's not great, but it's there. If you have stage 4 CKD, less evidence that you're going to protect the kidney. It won't hurt it, but you won't necessarily help it. And if you're on dialysis, the recommendation now is if you're on a statin, you can continue it, but if you are not, you should not start it because there's no evidence that it really does anything. Now that comes from the 4D and the Aurora trials that were done a number of years ago in dialysis patients. So the reason to give it is to reduce cardiovascular events. If you're thinking you're protecting the kidney, and you've already heard some data on this earlier, you're really not, unless it's early stage kidney disease. Which one's better? Well, rosuvastatin, of course, in advanced kidney disease may not be as safe as atorvastatin, and atorvastatin has a lot of data in people with kidney disease, and so atorvastatin is generally preferred over rosuvastatin in people with GFRs of 30 or 20, etc. The fibrates are interesting. There's no clear message about the fibrates.
You
There's
can
no
continue.
clear, okay, there's no clear message about fibrates. Fibrates certainly, theoretically, they should be able to protect the kidney, but they kind of don't. I mean, there's been no real trial. There's some evidence they reduce albuminuria, very soft evidence. So I don't think if you were to poll 100 nephrologists, they would tell you fibrates are saving the kidney. So if you need them for triglycerides, then you should use them judiciously. Otherwise, I certainly would not recommend them routinely, and I certainly don't use them.
There's a lot of interest in MRAs, and the new data is coming up on finerenone, which is supposed
Yep.
to be 500 times effective, specific, and about 3 to 5 fold very potent. What is your take on these MRAs, which on one hand are supposed to produce hyperkalemia? That's why we're worried to use them. We're very scared to use them, but the report says they're very effective and very useful in delaying the progression of the disease. What's your take on that, sir?
So I will tell you, finerenone, the non-steroidal MRAs, so finerenone is a non-steroidal, really have a very different profile. And as you correctly pointed out, their binding is very different. The data that has been published so far, number one, the signal for hyperkalemia is about 50% less than what you see with Spiro. Number two, they have very powerful antiproteinuric effects independent of blood pressure reduction. So they do not reduce the blood pressure like Spiro does. You maybe get 2-3 millimeters. That's it. So the argument is that these are working via an immunologic mechanism on the monocytes and the T cells, etc. And there's some pretty good basic science data that is evolving with this. There's actually a supplement in Diabetes, Obesity, and Metabolism that was just published that actually focuses on this. So I think it's important to understand that this is not your mother's spironolactone or eplerenone. These drugs should not be thought of necessarily as potent antihypertensives, but maybe immunologic modulators that are working in concert with ACEs, ARBs, and SGLT2s. And in fact, what I didn't say during the talk is we have a subgroup in the Fidelio trial of a little over 4% of the total group, that's 4% of 5,700 people, on SGLT2s. That's already a pre-specified analysis that we're going to look at to see if there's any kind of potential additive activity.
But sir, you said it has a very poor antihypertensive property. When you look at the patients with resistant hypertension, the PATH-3-2 trial by Brian Williams, which said that those patients who were not controlled with antihypertensive drugs were put on the mineralocorticoid receptor agonist, and they did extremely well. The pressure control was very nice. So therefore, the corollary that if you have a patient who is resistant hypertensive, and if you want to treat his hypertension, you use MRAs.
So this is what I'm trying to tell you. There's MRAs, but within MRAs, you have to divorce steroidal and non-steroidal. The steroidals, meaning spironolactone, absolutely, no question. The non-steroidals do not have anywhere near the blood pressure lowering ability that spironolactone has. And part of that is their specificity, and that's what I'm trying to tell you, is you can't lump them together. They are very different, as you implied.
What is your take on the ASK1 inhibitors, which are supposed to be anti-fibrolytic drugs. And a lot of human trials coming up. About 300 odd patients were given this molecule. Patients of kidney disease shown a very promising response in reducing fibrosis. It's also a drug which is used for NASH patients as well. Even in NASH, it showed some amount of improvement. Are some of the trials that are going on in this field?
Yeah, I am not involved personally with those trials. I'm aware of some of them. It looks very exciting because it seems to be hitting kind of a central mechanism. And that will be amazing if they are positive, because it may actually provide a mechanistic way of prophylaxing and preventing fibrosis before it even starts. So I remain very optimistic on that.
I think, Sanjay, you have any questions to ask?
We should very much, George. I think we had an excellent lecture from you, and this was the perfect winding up of a great meeting that we've had over the last 2 days. Thank you very much, George. Thank you very much, Vijay.